continue, and now we will go to the last battle of today, battle number 4. And I have the honor to be chairman of this battle. And the question we have to answer is, how fast can we actually go when we place implants? Should we use an immediate approach or a late approach? And to discuss this topic, we have two very, very well-known presenters. We have Tiziano Testori from Italy. He works as head of the implant and all rehabilitations center at the Institute of Galilei, and he is also a clinical associate professor at University of Michigan, and he has a very huge amount of publications also within this area, so we look very much forward to his presentation. The opponent who had to argue for the late approach is Maurício Araújo, and most of you may know him as a periodontist. He works in Brazil. He works in a private practice, so he has a lot of clinical experience, but he is also related to the University of Maringá in Brazil. He had been at the same Scandinavian institute as I have been. He had been at the periodontal department in Gothenburg, not at the same time as me, unfortunately, but he had learned a lot about histology, I know, because everyone who comes there learned a lot about histology. So I also hope that we can have a little bit discussion about the histological background for placing implants immediately or late. Tiziano will speak about and argue for the immediate approach, and he has a lot of background. Also, when he goes to the literature, he will do so. This is 2 of his recent publications where he is involved and where he have follow-up of different cases. As you can see here, a first premolar is immediately extracted, and the implant is immediately placed in the extraction sockets, and a temporary crown is placed. And as you can see on this slide here, there is a follow-up for up to 5 years in this publication. So the question is, why should we actually go so fast when we have a premolar? And maybe it looks quite nice on the radiographs, but is it a predictable procedure? Can we have problems in the future when we do an immediate implant? And do we have any restrictions? I look very much forward to hear about this. When we go to Maurício, then he had made a lot of publication. Now I have selected one he did recently last year in periodontology, together with our 2 very wise Swiss colleagues, and where they actually looked at different types of bone. And that will be one of the questions today. Do we see any difference when we talk about a thin wall phenotype buccal bone compared to a thick bone wall phenotype? You know, we have also other classifications of bone, but they used it in this sense. We will also discuss about the influence of the soft tissue, or we will make the question, does it influence whether we have a thick soft tissue and a thick biotype of the soft tissue, and the same if we have a thin, or does it matter?
Hello and welcome here at the...
You can see on the A, when we extract the tooth, we can lose the buccal bone, as you can see on the B. And if you look at C, you can see a beagle dog case where they have lost a lot of bone at the buccal. How can we predict the amount of bone we have at the buccal aspect? This is one of the questions. And do we, as humans, react as the beagle dogs? And can we then put bone substitutes in the extraction sockets to have a preservation, a socket preservation, and can we do that when we do it immediately, or can we only do it when we do the late approach? I hope we can have the answer on this question too. And when we look at the last slide here, then we can make the question, do we actually need to use such a wide implants? Could it be an idea to have more narrow implants placed if we do it immediate? I look very much forward to have these questions answered, and the one who can answer them, or the two who can answer them, is Maurizio and Tiziano. We will start with Tiziano, who will come with something with a background, then Maurizio will come with a background, and then you have the opportunity to come in with questions, as you have seen before, at the app, and we will try to take some of the questions and have them answered by the experts. So please, Tiziano.
Thank you, Klaus. Good afternoon to everybody. I would like to thank the President and the Board of the EAO. It's a great pleasure to be here and share with you our thought and knowledge. First of all, a brief review of what's in the literature regarding immediate placement and immediate loading. This is one of the meta-analyses that we wrote with Massimo Del Fabbro. And no matter, we should say that randomized clinical trials are not so many in the literature. You all know that. So there are free controlled clinical trials and case series in this meta-analysis, and the conclusion is that the better outcome when you go in healed bone compared to post-extraction sockets. So that's, but anyhow, conventional protocol still remain the gold standard, but immediate restoration in fresh extraction socket display excellent implant prognosis, but we will see during the clinical presentation when we can do that on a predictable base without jeopardizing the outcome. Always remember that the patient, especially when aesthetics is a concern, is coming for having a beautiful teeth, not an implant that is osseointegrated. We give that for granted. So what about soft tissue and hard tissue changing following immediate placement? This is a more recent one, and again, we see that in the aesthetic zone, we can have similar hard and soft tissue changes compared to conventional protocols. Another meta-analysis last year came out, immediate implant placement into fresh extraction socket versus delayed implant in healed sockets, in native bone, let's call it. Immediate implants should be performed with cautious because significant lower survival rate compared if you have a lot of bone, if you have a healed ridge. Everybody of us is able to just place an implant and have clinical success. So caution is always a word of wisdom when aesthetic is a concern. And then we have another important paper from the Journal of Periodontology with at least, it's not a very long follow-up after functional, and it adds an additional factor. Immediate implant placement in thick biotype with immediate provisionalization had less mid-facial recession compared to thin biotype. That's what's in the literature. That I will tell you what we do really think, that in medicine there is not only one factor, it's a multifactorial situation in which different factors, they play a role. But thin and thick biotype, it's one of the factors. We had the opportunity in this paper that was cited by the chairman to compare two groups, and the cumulative survival rate was 96.5. Immediately loaded and delayed loading, no difference in mean bone crystal loss, and the aesthetic score, because if we deal with the aesthetic, we should use one of the aesthetic score in the literature was quite favorable. And the immediate loading in our data set does not influence the outcome, meaning that the long-term prognosis of fresh extraction sockets. There is always one problem when we deal with post-extraction, because if you are extracting teeth, there should be a reason. Usually it's endoreason, periolesion. And I do think that infected site is a misleading word if we translated that in many languages, meaning that when you have a periodontal lesion and it's not acute, when you have an endodontic lesion and it's not acute, you do not find bacteria in the bone. So evidence suggests that sites with periapical lesion and periodontal infection, if you debride everything very careful, you can place implants in a predictable way. So it seems that periodontal and periapical lesion are not a contraindication. These are the papers, some animal studies, some clinical studies, the evidence in the literature. Our paper that we published in 2009, these are the papers within this review. Another review, 2015, immediate placement into infected sites, high survival rate, support the hypothesis that you can place implants immediately after extraction, presenting endodontic and periodontal lesion, and again, appropriate clinical procedure. What does it mean? Meticulous cleaning, socket curettage, debridement. So the message is, I'm not going to extract a tooth and immediately place the implant without taking care of the periodontal or periapical infection. We should debride and we should place a lot of attention. You know that in dentistry, and implantology is a branch of dentistry, I mean, little details, one after the other, they do make the difference. They do make the difference. So your learning curve plays a role, and how meticulous you are, that could make the difference. Then we published last year our research showing 369 patients who received a total of 527 implants, so it's a quite large data set, comparing infected site and non-infected site, and we saw no difference. We are a team of 5 surgeons working more than 20 years together. We started in 95 working together at the San Paolo Hospital before and then at the Galeazzi Hospital. So we are an homogeneous group. So the knowledge that we share within our group, it's a combined effort of everybody of us. Why I'm telling you this? Because you should take into consideration, and we will see during the conclusion that this can play a role, is an efficacy study or an effectiveness. Is it a true word, or it's a word of people that are doing on a regular basis implant dentistry, and this external validity cannot be generalized? That's the question that we should ask ourselves. But statistically, no difference between the two groups. So could be our conclusion could be a safe option, even if the implants are immediately loaded on early loaded in infected sites. It's still online, this new piece of information, and this new piece of information tells you that immediate implant placement into infected sites versus non-infected in the aesthetic zone at similar survival rates, bone level changes, and you know that to have a stable bone level, it's very important to have long-term stability of your crowns. And again, the patient are looking for beautiful teeth, and these teeth, they should stay beautiful for long term. And gingival level changes. And if you see in the forest plot comparison evaluating the survival rates of the implant, even our study was in this meta-analysis, and so you can have the number of studies, the number of infected sites and non-infected sites, so you can have an idea what's in the literature. And this is the failure rate, and all the failure rate, they tell you, clinically is very important, that if they fail within 1 year. So the failure rate as a clinician is very important for us. So if you want to be on the safe side, place the provisional. The longer you wait, the more failure you will see with the provisional, because after 1 year of loading, in immediate loading, you will see most of the failure. Most of the failure, 80% of the failure within 6 months. If you wait a little bit longer, an additional failure rate you will see. But once you have loaded that implant, that is immediately loaded, and that implant is stable, the failure rate after 1 year of loading will be very minimal. So that's an important clinical issue that with immediate placement and immediate loading we should know. Which kind of conclusion can we draw? That, as we know, there is not a unanimous consensus in the literature regarding the survival rate, regarding different factors in immediate loading. But we can say that could be a routine treatment in our group and in many places around the world. Is it technique sensitive? Yes, it's technique sensitive. Why? Because it's much easier to place an implant in a healed bone. It's not so easy if you are a beginner or intermediate to place an implant in an extraction socket, because everybody of us knows that the drills are not so stable in an extraction socket, and you got to have a learning curve even if you use guided surgery. Caution in the aesthetic zone, because I will show you in the clinical stuff that when you have a disaster, an aesthetic disaster, it's not so easy to do everything. You should maybe take the implants out and redo everything. So always think that an aesthetic disaster in the front area could be a big problem for your patients, because patients, they are not looking for an osseointegrated implant, they are looking for aesthetics. And always know the biological limitations, but the biological limitation will be presented by Maurício Araújo. And by having said that, I will be thanking you, open for questions, and let's show the clinical stuff later on, because that's how the Klaus and Robert just gave us this. So Klaus, I'm done. Should you?
Thank you so much for this very nice presentation. And now we really have the background. And I don't think you all agree in what he said. Do you agree that we can place implants in infected size? And what about the aesthetic ones? We can see we have some cautions, and we should discuss it, and you're very welcome to make questions. But before you make the questions, we would like to have the other opponent on the stage, and that is Maurício. So please, Maurício, come on the stage and make your arguments, please.
Good afternoon, ladies and gentlemen. Good afternoon, Mr. Chairman. And I should use this, or I should do that one, right? That one. Yes. Well, my role here is to present you my presentation, and the title will be How Fast You Go. The aim of my presentation is to answer to that very question. How fast can we go? And what is the role of late implant placement in current implant dentistry? So that is the aim of my presentation. And but to start to answer this, I do have to describe the environment in which I will work. That will be very important to answer to that question. I have to describe where I'm working. Well, I work here. And let me describe to you the alveolar process. The alveolar process is defined as the bone that surrounds the root of a fully erupted tooth. And you can see it just below this green dotted line. This is the alveolar process. Now, above the alveolar process, you identify the basal bone. That, in the case of the maxillar bone, is limited by the floor of the nasal and sinus cavities. Now, let me go a little bit deeper. Now you can see the alveolar process in the CBCT scan. Again, you have my green dotted line above the basal bone and below the alveolar process. To your right, you're going to see the same. Again, my green dotted line above the basal bone and below the alveolar process. Now, I'd like to tell you something. The alveolar process is made of two types of bone. One that faces the root surface, that is in contact with the periodontal ligament, that is called alveolar bone proper or bundle bone. And the other one, the remaining bone, that is only called alveolar bone, that is similar to the bone of your remaining skeleton. Now, let me show you this bundle bone. And you can see here in higher magnification to your right. As you see, it's called bundle bone because it contains the collagen bundles from the periodontal ligament. Indeed, bundle bone is much more similar to the dental cementum than to the remaining bone of the alveolar process, to this bone from your skeleton. Think about the bundle bone as a mineralized part of the periodontal ligament. In the same way, the dental cementum is the mineralized end of the periodontal ligament that connects the tooth to the periodontal ligament. The bundle bone is another mineralized end of the periodontal ligament that connects the periodontal ligament to the skeleton of your patient. And the combination of bundle bone, periodontal ligament, and dental cementum ultimately will connect the tooth to the skeleton of your patient. And by the way, periodontal ligament, dental cementum, and bundle bone are produced and maintained by the same cells, the cells from the periodontal ligament. So when I extract the tooth, I remove the periodontal ligament and I remove the cells that produce and maintain the bundle bone. So it's a very important piece of information. Why? Because when I see this, you can see here the buccal wall, right? How much of this buccal wall is made of bundle bone? In other words, this mineralized periodontal ligament doesn't belong to the bone, belongs to the periodontal ligament that in turn belongs to the tooth. It's tooth-dependent structure. How much of this is bundle bone? This is very important because if the entire thickness of this is made of bundle bone, the moment I extract the tooth, I may lose the entire buccal wall. Now, to answer to that question, I have first of all tell you what is the thickness of the bundle bone. That's something that you can only see under the microscope. You cannot see bundle bone with your naked eyes. So let me show you a histological section of this canine. Here again you can identify the basal bone. Below the apex we have the alveolar process, and to your right you can see this very thin buccal wall. right? I'm going to show you in even higher magnification to your right. Now you can see from the left to the right, the dentin, light pink, then dark pink, you can see the dental cementum, then you can see the periodontal ligament, and that stuff, light pink again, this is the very thin buccal wall, and then you can see the soft tissues. Now, how much of this is mineralized periodontal ligaments, bundle bone? In this particular, for this particular specimen, for this particular human being, I can show you that the entire thickness is made of bundle bone. Everything there belongs to the periodontal ligament. But what is the average? That was measured by this gentleman, that's Professor Robert Schroeder, and he stated that the thickness of the bundle bone in humans goes up to 0.4 millimeters. Now, keep that in your mind. Now, let's measure the thickness of the cortical bone. The thickness of the cortical bone. That was evaluated in many studies, including that particular studies in which we took 250 individuals and we measured the thickness of the cortical bone in 3 different levels, 1, 3, 5 millimeters below the bone crest. And by these average numbers, you can see that average thickness is 0.6 millimeters. So let's say half millimeter. It's very thin. Now, let me show you, this is an average number, right? Half millimeter. Let me show you a frequency distribution of these numbers. So these frequency distribution tables, they show the percentage in which you're going to find buccal walls that are less than half millimeter. What does it mean? The entire thickness is made of bundle bone. But now there are some percentages, more than half millimeter, but less than 1 millimeter. Most of the buccal wall is made of bundle bone. But there are some percentage that represents more than 1 millimeter thick buccal wall. Now it's different. More than 1 millimeter thick, meaning that most of the buccal wall is not made of bundle bone. It's made of alveolar bone. As you can see from that frequency distribution table, only about 15% of the buccal walls are thicker than 1 millimeter. So 85% of this, most of it, is made of bundle bone. Now let's keep that in mind and let's describe a little bit more the alveolar process. Now I'll show you this. This is a paper in which we describe the basal bone, the alveolar process, the thickness of the buccal wall, the inclination of the roots, the location of the apex, many things. But I only like to show you two results from this descriptive paper. The first one is this. The dimension of the basal bone, because from time to time you may need basal bone when you do immediate implant installation because you need primary stability. So what's the dimension of this? It varies from one tooth region to another. As you can see at the K9 you have the smallest, the narrowest, and the shortest basal bone. And then we follow to the center incisor and then to the lateral incisor. That's where we have the largest basal bone. Also, I'd like to tell you from that particular paper that the width from buccal to palatal dimension of the alveolar process, the pristine alveolar process, is about 9 millimeters. Also keep that in mind. In summary, there are some changes between the tooth regions in the anterior region of the mouth. Now, and talk about some differences. Let me show you these two cases, two lateral incisors, right? Let's look to the left. I have a lateral incisor with very wide basal bone, very thick buccal wall. Now you know that this is very thick. We can also see that the apex is located far away from the cortical buccal bone, and also that the inclination of the root is such that if I draw a line parallel to the long axis, I can show you that this socket, this root, is right inside the basal bone. In other words, this is inside the bone envelope. And this might be important. Let's compare to the other patient. Now I have a patient with a narrower a basal bone with the apex at the buccal cortical bone, with a buccal wall that is very thin, I barely can see it, and with an inclination of the root such that if I draw a line parallel to the long axis, you can see that this root, this alveolar socket, is outside the bone envelope. Now, imagine that I have to extract these two lateral incisors. Imagine. You can imagine that to the left, the blood clot will be well protected by the thick buccal wall and the thick palatal wall. All the healing tissues will be well protected. Not only that, to the left, I have a large availability of bone cells and blood supply. But to the right, the moment I extract that tooth, I may lose the buccal wall, and the soft tissues will collapse in the space previously occupied by the root, because the blood clot cannot resist the pressure from the soft tissues. And only by that, I'll lose a lot of volume. And also, here, as you can see, there is much less bone cells availability and blood supply. So there are differences among the tooth regions. Now, let me show you this. Now, this is not the alveolar process, this is the alveolar socket. As you can see, the alveolar socket is a very nice, let's call, bone defect. It has 4 walls. These 4 walls will provide a very good blood clot stability, if they are there, will provide a very good availability of bone cells and blood supply. And not only that, on the top of this bone defect, we have this beautiful soft tissue that will provide cells that will close the entrance of the alveolar socket. Now, to understand why such a beautiful bone defect may heal not in the ideal way, I have to explain to you the socket healing process. And I show you this single slide to summarize the socket healing process, in which I had described in that particular paper what happens following tooth extraction. As you can see, I have 4 buccal-lingual different histological sections representing 4 different time intervals. As you can see, at a 1-week time interval, the socket is occupied mainly by provisional connective tissue. At 2 weeks, this provisional connective tissue was replaced by woven bone. At 4 weeks, the entire socket is occupied by woven bone. At 8 weeks, this woven bone was replaced by bone marrow lamellar bone. But mostly important, what I want to show you here is that the shape of the alveolar process has changed. If you follow these dotted lines, you can see the lingual and buccal crests. While the lingual crest is more or less at the same level, the buccal crest decreased. And not only that, I not only lost buccal wall in vertical direction, I lost an overall volume of the alveolar process. What I want to tell you that during socket healing, process of bone modeling and bone remodeling will change the dimension of the alveolar process. And by that, the reach will be reduced. Now, finally, I'd like to show you this. This is a clinical study in which we are going to compare heel sites, alveolar reach with alveolar process. Now you can see clinical variables describing the alveolar process and the same tooth region after 1 year of healing, right? Now you can see the before extraction and after. The second column is before extraction, the third column is after extraction. Now, these first 2 lines, they represent the basal bone. There is no much change at the basal bone following tooth extraction. However, if you follow the 3rd, 4th, 5th, 6th, and 7th lines that describe what happens in the alveolar process, you can see there is a big change. In terms of cross-section area, 30% of reduction. In terms of width, about 50% of reduction. And by the way, look at these numbers. Let me point out something very special. If you look to that number, that pointed by this red arrow, you can see how much reduction, how small the alveolar ridge becomes falling tooth extraction at the anterior regions. It means that very likely in the hindsight you may need ridge augmentation. While here, if you look to this dimension before tooth extraction, that's a dimension that would hold easily an implant. So if you're able to preserve that dimension, not 100%, let's say 85% of that dimension, it's enough to hold an implant. Thus, the dimension of the ridge is reduced following tooth extraction. And finally, this is a paper that was presented by our chairman that shows, again, the importance of the buccal wall. And now you know why the thickness of the buccal wall is so very important. Here, Dr. Chapuis identified these 39 patients. She took CBCT scans at tooth extraction 8 weeks later. And she showed that in patients with less than 1 millimeter of buccal wall, we have 7 times more vertical bone loss than patients with 1 millimeter or more of buccal wall. Thus, tooth extraction should be performed with the acknowledgement that ridge reduction will follow, and that you may need to take that into consideration. Thank you very much. Sit there, sit there.
Thank you so much, Maurizio. That was a very good biological argument not to place implants immediately in extraction sockets, or we will see. And we will also continue with some clinical cases. But before we do that, Robert had collected some of the questions from the audience, which you will make to our 2 presenters before we go to the clinical cases.
Yeah, thank you very much for everybody who is taking place in the questions answer section. So, Tiziano, there was a question from the audience. Would you recommend in putting some platelet-derived factors like the platelet concentrate into the gap in between the implant and the buccal plate?
We don't do that. We are placing some biomaterials, lowly resorbable, that will hold the volume.
But not a factor that promotes bone healing?
No.
Mm-hmm.
No platelet-rich concentrate in between the gap. We are not doing that.
Araújo, you have presented that that the ridge is actually narrowing between the healing, and you have made some tremendous research on that topic. But looking at your publications, you told us that you can keep the width and the height of the alveolar ridge, but when you look at the bone formation, it's quite a different topic. So the bone substitute may interfere with new bone regeneration. Is that right?
Well, whenever you do a surgery, it somehow interferes a little bit, especially in a bone graft. The idea is to know if this interference is for the better or for the worse. And I believe in terms of ridge preservation is for the better. And after the break, I hope I will be able to show that. So, I think it's worth to think about some clinical procedure to prevent unnecessary bone reduction. I believe it's worth.
So you're more eager to prevent bone reduction than produce major bone or bone you may use for implant. So
good question.
Quantity before quality.
Very good. We have I'm a periodontist. If I see a 3-wall bone defect, if I see a 3-wall periodontal defect that is 6 to 4 millimeter deep, it's heaven, right? But now I have a 4-wall bone defect that's not 4 to 6 millimeter deep. It's 10 to 12. I mean, this is wonderful. I'm not talking about, the problem is not bone formation. The problem is about the maintenance of the bone that will be formed inside the socket. Unless your patient has a systemic disease, I mean, it's a 4-wall bone defect, why should we not have bone formation? But the point is that bone will stay there or not.
Mm-hmm. Tiziano, and
Yes.
what you think about, and there are some questions, especially this one, coming from the internet, so I want to remind you that this session is transmitted over the World Wide Web, so worldwide.
Yeah.
And one from the web question
big
is
stars now.
regarding the immediate abutment. What's the importance of putting an immediate abutment at this?
One abutment, one time.
One abutment, one time. Yes.
We will address that in the lecture, but it's not the critical issue. It's not the critical issue.
And one technical question to Araújo, the last one, then I think we should go on with the clinical presentation. How this was from the audience, how was the thickness of the buccal wall measured? Because you did some quite accurate measurements on the buccal
No.
thickness.
Well, in terms of histology, that won't be a problem because you can even measure cells, whatever, so it's very accurate. It's not a big issue. You know?
Okay. I think that we have not answered all the questions. There will be a lot more, and I think there will be more when we have the clinical cases. So I'm sure you can
Thank
prepare
you.
someone. So I will thank the presenters and also Robert for the questions from the audience and the answers to them. And now I will ask Tiziano to
Present the
continue
clinical case.
with the clinical cases.
While I'm waiting for the screen, since I broadcast all over the places, always think that in medicine there is not only one factor that plays the role, it's a multifactorial issue. So the abutment is important. If you can do one abutment one time, fine, but not multiple, super multiple disconnection. But if you do on a clinical basis 2 times, that's fine, doesn't make any difference clinically. There is the lady that is a nightmare because she has a very beautiful crowns that if you read some of the literature, we can say that is a clinical, it's a success because there is no bone loss, the bone is there, but would you add this clinical case in your practice? It's a disaster. The patient is not a lady. You can make an unhappy patient throughout their life if you don't take care of this patient. Why? Because it's made without any biological knowledge and without a thought process taking into consideration different factors. So I'm here to show you what you can do on a predictable basis, picking up the right case for immediate implantation. So let's review together what we are looking for. First of all, is a patient with a fistula and some reason for extraction. Why reason for extraction? Because the external root resorption is very close to the periodontium, so it's not so easy and predictable to have endosurgery. Otherwise, if you can save teeth, good, save teeth, do only one implant. So this is the situation we are looking for. Class 1 can classification, a lot of bone in the apical position, wide ridge, triangular shape where we can get good primary stability, 4 millimeters above the apex of these teeth. This is a video showing you the buccal wall, the anatomy Maurício was showing to you, the axis of the implant that allows you to place the implants more palatally oriented without jeopardizing the buccal wall, thick buccal wall. So we wrote a paper in the Journal of Periodontology 2000. The first name is Joseph Kahn, and this is diagnostic parameters that you should evaluate. So different parameters, the gingival level in relation to adjacent teeth, the osseo tissue relation on the facial aspect, the bone sounding, where the bone is compared to the soft tissue, the gingival biotype, the sagittal root position, very important, the labiopalatal width, more base of vascularization, more stable is the tissue, the intraradicular width. We came up with this idea, and I discovered, because we didn't speak to each other, with Maurício, that is validating this idea that I have with another periodontist in Milano, Giulio Rasperini, to have an objective tool to differentiate the biotype. And then when we got to the procedure, first of all, think about that you should remove the fistula tract. Why? Because Tron study 91 in the Journal of Endodontology and Dental Traumatology show us that you can have a calculus inside the fistula, and this is in the endoliterature, extraradicular plaque colonization of the root that prevents the most beautiful endodontic treatment to have clinical success and healing. So if you do implants, remove the fistula tract and debride everything. And before placing the implant, you should know how to extract the teeth atraumatically. It's longer, it takes more time to section the teeth, like the one that you see here with the piezo, with the burr, mesiodistally, and then another vertical cut. It takes longer than placing the implants, as you see here. So then another vertical under the loops cut in order to extract the teeth in pieces. Why? Because we want to preserve the bone. Maybe it takes 40 minutes, 30 minutes, and 30 seconds once you have clear idea of the position of the implant to place the implants. And then socket mapping, understanding, you know, on the CAT scan, we just evaluate the CAT scan, and now we see everything clinically. We do bone sounding to understand the type of socket that we have. And then, again, placing the implants with these axes, and think about the 3D image at the center of your screen where I'm going to place the implants. And 85% of your patient, and this is the frequency distribution of the sagittal root position classification according to Kant published in 2011, class 1 is the one that most of your patients will have, and this is the safest area in which you can do immediate placement and immediate loading. And then why? Because in that kind of situation, anatomical situation, you can get and achieve good primary stability. And primary stability, according to our knowledge, is more than 45 Newton centimeter. And you got to have an objective tool to evaluate that, a drilling machine or a manual torque controller. And again, which is the best position in those cases? The best position, according to our ideas, is the long axis aiming to the incisal edge of the future restoration, along with the straight abutment. Why straight abutment? Because it leaves more tissue to fill in, and the thicker the tissue you have, the better the situation long-term will be. Meaning then the prosthesis plays a role. Do not focus too much only on the surgical phase. The prosthetic phase in our mind is the last part of the surgical phase. And a good prosthodontist can save the work on an average surgeon and not vice versa. So this is the position of the implants we are aiming. And a good friend of mine, Ernesto Lee from Penn University, just called the lingualized position, but we scan his paper aiming to the incisal edge, just rewarding that. And then we place the implants and we leave an intentional gap. No guided surgery, long, very old cases is better, and we stated in our paper this year, it's better to go guided because flapless, you can perforate if your learning curve is not at the highest level. It's not so easy to go flapless and to have, it's better to go maybe with guided surgery. You stay on the safe side. And a good friend of mine, Tommy van der Velde, showed that many years ago that even on a bench study, you can have perforation in a flapless mode. And then, I am a surgeon, I should look and I should take care of the contamination, so I'm using peak abutment, but I'm not using the burr. I'm using a very sharp scalpel to cut down the peak abutment. And since I'm only doing the surgical phase and not the prosthetic phase, at this point, I lend the patient to the prosthodontist, and the prosthodontist takes 2 little shells, 2 little provisional, and pick up the position of this peak abutment. Is not doing the whole procedure. It's just picking up the position with a little flowable composite on the lingual side, and then I'm going back. I flush, I clean, I fill the gap, I place a collagen sponge, or at this level, I can place a little bit of PRF to keep my graft inside the socket, and then the prosthodontist in the lab refines the shell, polishing everything, and clean abutments, meaning ultrasound, meaning under the steam, meaning chlorhexidine. It gives me a provisional that are clean. Provisional that are clean. I flush inside, I clean inside the chamber, I place the abutment, and you can see how bulky are the teeth, no more than natural teeth. That is important. And if you are aiming at the incisal edge, that's the position you should have. And this is 1 week, 2 weeks, 4 weeks, and this is the follow-up. And then at 4 months, if you are thickening the tissue, not only because of the implant position, the right place, but even because of the straight abutments, and you have the critical and the subcritical contour. And when you superimpose, then me as a surgeon, I should put the implants for my prosthodontic 3 to 4 millimeters, no more. And that's the abutments that we do. So we do think that the prosthesis plays a role in the final outcome of the restoration. This is 8 years post-op, and this is the situation that you will see 8 years post-op, but we started with the ideal situation from the anatomical point of view, from the soft tissue point of view, from the implant point of view in terms of axis. So it's a multifactorial situation. And so you see down the road the thickness of 8 years post-op. That's another case. The last case, same old situation, and this is the situation, the anatomical situation. We start the class 1 frequency classification according to Khan study, where I can have good basal bone, 4 millimeters, 3 millimeters of basal bone, in order to get a good primary stability of my implants immediately loaded. And then, again, a traumatic extraction, do your fibrotomy. Don't skip that. Why? Because you will have the possibility to get your forceps a little bit towards the coronal aspect of your implants, of your root that are going to be extracted. And then you have seen the perio probe, the biotype probe. And then if you're learning curve and you don't want to do guided surgery, maybe prepare the site with the root inside might be easier because your drills are not skidding, because they are not touching the cortical, and then you can verify the position, and then all of a sudden you got to extract that root, but the axis of the implants is already made, and that's the tricky part of the situation. And then we place our implants, and then we leave the intentional gap. That's a healing abutment, 3 millimeters long, to show you how deep is that implants. 3 millimeters below the soft tissue. And then I'm filling the gap. And since I'm doing only the prosthetic part, I'm always concerned about the contamination. And if I have the right situation, I can put an intermediate abutment, so my prosthodontist will work above the tissue, not going directly to the implant head, and is using the same shell, the same tooth of the patient, only the vestibular part of the tooth. So this is the tooth of the patient that has been bonded to the abutment. So the patient lives in this situation in which he has a very stable implant, 45-degree plus, and the vestibular part is the tooth of the patients, and this is the final restoration. The patient likes to have the chipped incisor, and we are just fulfilling the desire of the patient. Do not change my chipped incisor. We have to take into consideration that, and this is what I like to show to you. Down the road, 4 years down the road, the cortical layer, the buccal bone, the situation we have, and the stability of the soft tissue and the stability of the hard tissue. Which conclusion can we draw together? Again, the conclusion that immediate placement and provisionalization can be done, but you should follow the guidelines in terms of diagnostics, in terms of surgical procedure. And if you have a score that gives you the idea of how difficult is the case, you can pick up the case according to your learning curve. And what I was showing to you, it can be done by each of you, taking into consideration that it's a multifactorial situation, and not only one factor plays the role. Are we in the real world, or are we on a podium showing you the most beautiful cases? No. There is a protocol. There is some factors that you should take into consideration, because in the real world, take this as a message, the result means that implant survival and success rate in general dental practices may be lower than those reported in studies conducted in academic and specialty setting. And always think, when you are seated there, the external validity of what I'm showing to you can be generalized, it can be transferred in my clinical practice, yes or no? And last, use one of the aesthetic score in the literature. This is our aesthetic score. Use the one that you like, but use an aesthetic score, so we can have an objective tool to verify our work. And by having said, thank you so much.
Thank you very much, Tiziano. Very nice cases you showed. So we can see that it is possible. The question is when it is not possible, and I think we will come to that in the discussion. But before we do that, we will hear the clinical and listen to Maurício about the clinical cases he had selected for today. Please, Maurizio.
So, I told you before that following tooth extraction, there will be a reduction of the alveolar, of the dimension of the alveolar process. How can we prevent that? What should we do? Leave it happen, or should we do something? Well, there are two options, as I see, at least. First option is that when you see a tooth that you might need to extract, let's say that you want to extract that particular tooth for any reason, you have to decide if this volume is enough for you to maintain for what you're proposing. I don't know if you're proposing for late implant placement or for immediate implant placement, but is the proper dimension. Now, Dr. Testori was describing the characteristics of the alveolar process for immediate implant installation. So, have to decide, is this dimension enough for you? Because if it is enough, you want to preserve. I know that if I do nothing, there will be a significant change. Now, if this is good, I want to keep this way, and this is called ridge preservation. That's a procedure that preserves the ridge volume within the envelope existing at the time of tooth extraction. So I have to take that decision. Now, if I believe it's not enough, that I have to put something on the top, I go for ridge augmentation. That increases the ridge beyond the skeletal envelope. So let's suppose that I look to this, again, the same case. And I decide that for what I am planning, this is no good. That's not good enough. Then I have to augment. So I'd like to start my presentation by saying that we have to take that decision. Is this a good dimension or this is not a good dimension? Now, let's see to these 4 different patients. Now, I have 4 different CBCT scans. Now, some of this goes for ridge preservation, some another for ridge preservation, for ridge augmentation. So, obviously, as I see, when I look to patient number 1, that I have a large basal bone, very thick buccal wall, very thick palatal wall, the inclination is nice as well. Number 3, for me, it's clear that these guys, that dimension are okay. I want to keep that dimension as much as I can. I should do something to keep that dimension. And now, if I look to number 2 and number 4, this is impossible. I know that that dimension is not enough for me. I have to do something. I have to augment that ridge. So I go for ridge augmentation. Of course, I also have to say to you that if you have a severe soft tissue deficiency, you also should go to ridge augmentation and augment the ridge, the soft tissues as well. So I will tell you, don't do anything like preserving the ridge, even if you are planning immediate implant installation or not. This is not the case. To preserve the ridge, you have to augment. Now, Dr. Testori mentioned something that it's very important. And let's get back to my previous talk, before the break. I talked to you about the buccal wall, how important the buccal wall is. Imagine the buccal wall as a reinforced resorbable barrier, right? It's a barrier that I told you, I described you that it will go away eventually. As thin as it is, it will go away faster. The thinnest, the thinnest, the fastest. Okay, that's fine. So it's really beneficial for you that when you extract the tooth, you take a long time to guarantee that you don't destroy the buccal wall remaining or the buccal wall that you have in case you have an intact buccal wall. Because it makes a big difference. Even if you tell you, I will destroy and put a collagen barrier, that's fine, but it's not the same. The buccal wall is not the same as a collagen barrier. right? So try to spend time. I would tell you the following. This is the simplest and cheapest technique to remove a tooth without breaking the buccal wall. Before me, Dr. Testori was presenting how to use the piezo. But there are several techniques, including this one that's very simple. That's for every single general practitioner to do. It may take time. It's much more difficult than do the graft I'm going to present to you, but this is important. Now you see a root with a longitudinal fracture that I have to remove. I'm going to take a burr and I will make a buccal palatal circles without reaching the bone, right? And now I have divided the tooth in two parts, one mesial and one distal. After that, I will take a root elevator, I will break the root. And you should always break the roots. You should always divide the root, even if a single root. Divide the root. And then I divided the root, and the piece that is mobile, I will remove. How? I take my peritome, I put between the outer surface of the root and the inner surface of the socket, and I move buccal and palatal, always at the mesial distal, and I move for 2 minutes. It takes 2 minutes to stretch the periodontal ligament. After that, you take your very fine root elevator or luxator, put in the space created by the peritome, and you move this piece and you remove. Now, the moment I have removed it here, I create that space in which, when I do the same procedure, peritome and root elevators, in the remaining portion of the root, I will push this remaining root into that space. And by doing that, because I had created a space, I'm not going to pressure the buccal wall. Fine, and then you remove it. So that's the first step. And I might say that's the most difficult. Now, the second is to put something inside the socket. That is my hypothesis, that placing something inside the socket that will stay there as a permanent scaffold for the host bone. That will be the best idea, because I know that if I allow only host bone to form here, there will be modeling and I will lose the volume. I need something that stays like a titanium implant. Why do I need a resorbable titanium implant, right? I need a biomaterial that is osteoconductive, biocompatible, that stays there. I don't have problems of osteogenicity. I have 4 walls, I have 3 walls. It's not the case. I don't need autogenous bone. I need something that stays. And for that, I always work with anorganic bovine bone. And that will allow that the bone that will be formed in this will stay here, because will be supported by this permanent scaffold. Well, I have performed several studies about this to prove this hypothesis that a non-resorbable, virtually non-resorbable biomaterial that will stay as a permanent scaffold is the best idea to preserve the volume. So you can see here one of these particular papers, I have grafted one socket. I did not graft one socket, while the remaining socket I grafted with an organic bovine bone. And you can see to your right how the non-graft socket healed. I have lost some buccal wall. I have a deficiency in the most coronal portion. The entrance of the socket is closed by a combination of woven bone, lamella bone, and most of the sockets occupied by bone marrow. Here you can see a socket that was grafted with my anorganic bovine bone. Now you can see that the socket is occupied by some bone marrow, some newly formed bone, and in blue, this is the biomaterial. I have lost the buccal wall, I always lose the buccal wall, always. But what happens is because I graft, this graft will act as scaffold, and by that compensate the loss of the buccal wall. And you can see to your right, in higher magnification, the uniform bone surrounded the biomaterial, and also to the further right, you can see that when woven bone is removed by the osteoclastic activity, it does not remove the biomaterial, allowing lamellar bone to be formed on the surface of the biomaterial. And the measurement shows that at the non-grafted side, I have 35% of reduction. The grafted side, I have about 10% of reduction. Why 10%? Because the socket graft is not able to preserve 100%. There will always be buccal bone loss in some degree. Thus, the placement of a biomaterial in the extraction socket modified for long periods bone modeling. Now, as I told you, the most difficult in preserving the ridge is not putting a graft inside the socket, is extracting the tooth. Here's a case, a typical, very didactic case in which I'm removing this for orthodontic reasons, this impacted tooth. And I have to preserve this volume until the end of orthodontic therapy. So I remove the tooth. I'm going to, in this case, it's not necessary to care much if there is any pathology. Obviously, there is no pathology, but nevertheless, when you extract a tooth, you have to be careful. Don't leave pathology inside the socket. And here I'm placing the biomaterial, and you can see after 2 to 3 years later, you can see I have lost the entire buccal wall. There's no more buccal wall. And you can imagine that if I had not done ridge preservation here, I would have lost everything, most of this ridge. Probably what will be left will be only this. And now I can place my implant with a very wide buccal wall, and you can see these white spots, they are the biomaterial surrounded by the newly formed bone. Of course, sometimes I extract a tooth and there is a big dehiscence. And now if there is a dehiscence, I have to compensate for the lack of this bone that would otherwise protect my healing tissues, even protecting the granules, because the granules, they need protection. Imagine, if the granules move, there will be no bone formation. So if there is a dehiscence, yes, you do have to put your biomaterial, but it has to be covered if there is a bone dehiscence here. Otherwise, this biomaterial will move, and then there will be no bone formation, at least in the outer aspects of your socket. And now after 4 months, you can see after a final osteotomy, this very wide buccal wall, and obviously that's what I mean by ridge preservation. Now we don't have to raise a flap. Honestly saying, I've rarely raised a flap for extract a tooth. And also to place a membrane, you don't need to raise a flap. If you extract in a minimally invasive way, take an instrument for tunneling. You do a tunnel, right, between the periosteum and the outer aspect of the buccal wall, and then you can place a barrier in this pocket. And also after that, you place a biomaterial. You can use this collagen barrier to close the entrance of the socket. And you put the barrier just under the palatal soft tissues. And that is also going to preserve the ridge. Now, is there evidence in the literature that such technique works? Well, there are a lot of literature, so let me show you one of these papers. This is one of my papers in which we took some patients and with intact sockets or presenting less than 3 millimeters of marginal buccal bone loss, bone fragmentations were allowed, but intact buccal marginal bone. In the test group, we graft the socket with an organic bovine bone, and we close the entrance with a gingival graft, while at the control group there was no graft. Here you can see the test sites immediately following tooth extraction. You can see the buccal wall, and after 4 months, the buccal wall is gone, but the volume was preserved by the graft with the biomaterial. This is my control. This is the conventional socket healing after 4 months. And that result shows that in both groups, there were buccal bone height loss, about 45%, while in regarding cross-section area reduction, there was 4% of reduction in the test group, while 30% in the control group. So socket graft with a non-resorbable, highly osteoconductive biomaterial is effective to compensate for bone modeling. Now, if you take the literature, all these systematic reviews, they are going to tell you that ridge preservation reduced post-extraction bone loss, ridge preservation decreased to 50% the need for further treatment, and the p-static scores are similar to the baseline or to immediate implant values. Of course, ridge preservation is not against immediate implant installation, because I cannot imagine somebody who is going to place an implant immediately and who doesn't want to preserve the dimension of the ridge, right? Doesn't make any sense. So it's not the opposite of immediate implant installation. So if you find the right characteristics of the alveolar process as described previously by Dr. Testori, you can place your implant and at the same time preserve your ridge. I mean, you should preserve your ridge. Why should you not? Well, doing socket grafts together with the placement of a biomaterial, is there any evidence, histological evidence, that this is beneficial for the implant? Yes, there is. So I can show you this particular study in which I had extracted the distal roots of the third premolars in both sides of the mandible and placed a 3.3 diameter in such a way that I have a wider gap. It's very important that you have a gap, at least a 2 millimeter wide gap. And then one side of the mandible I graft with my biomaterial, while on the contralateral side, no graft of the gap. And here you can see that's a histological section representing the sites in which I have not grafted the gap. Okay, I have osseointegration. You can see the implant is beautifully osseointegrated, but I have lost the buccal wall, and it might represent a static nightmare to you. However, where I had placed my graft inside the gap, you can see that the buccal aspect of the implant is covered by bone. Finally, why not immediate implant placement? In my opinion, well, not in my opinion, for obvious reasons. Patients are not available. Inadequate bone volume, if there is no bone enough to have primary stability. Acute infection, I mean by that pus oozing from the alveolar socket. But also, if you read these systematic reviews, that if your main concern is static, maybe there is a lack of predictability when you do immediate implant installation. Especially when you have a thin gingival biotype that you can change by doing a connective tissue graft, but also when you have a buccal wall less than 1 millimeter thick, that you cannot change. That you have to live with that. If you have a patient with a very thin buccal wall, you have to live with this. So in these situations, the predictability of the static result might be not so ideal, according to the literature. Thus, how fast can we go? As fast as predictable as possible. I have to tell a story if the Mr. Chairman allows me. Let me look at him. Do you allow me? Just before lunchtime, I was being interviewed, and somehow somebody knew my father, and he asked me, what was the influence of a father in your life? I mean, my father was not a dentist, he was a pilot, and I told that story to me. When my father retired after 42 years being a pilot, I asked him, please, father, tell me a very funny story about being a father, about being a pilot. Maybe it's like in a Hollywood movie. He said, listen, I have a very boring life. Every time I took off, I landed. As uneventfully as possible, I try to avoid anything because my passengers, they don't have a quick trip. They want to have a safe trip, comfortable. That's it. Nothing more than that. And what's the role of late implant placement in current implant dentistry? Is to compensate for the lack of adequate conditions for immediate implant placement. With that said, thank you very much.
Thank you so much, Maurício. I'm sure that all our patients want to have a safe treatment. And the question is now how we can give them a safe treatment. I think it was one of the things I learned at least was that we need to do much more. When we extract the teeth, we have to be very carefully and use more time in the extraction, not to damage the bundle bone. But Tiziano,
Yes.
we also heard from Maurício that about 15% had, or it was 15% who had more than 1 millimeter of buccal bone thickness, meaning that in these cases it was very difficult to do immediate implant placement instead of augmentation. Is that also your opinion, that it's only possible in a very few cases with immediate implantation?
If you want to be on the safe side, it's not like buying a hat in the United States, every size fits all. In medicine, you should do a diagnosis and a prognosis. So I pick up the right cases in which I don't want to have problems. I know exactly in the literature, there are even books showing you that you can place the implants without the buccal bone, and you place implants, but that's a specific situation. Can we do that on a predictable base in the average end of everybody? Is the external validity of those studies that we can promote on a large scale to do? No, I don't think so. The message is you should evaluate your patient, and every patient is different.
What is the important thing? You mentioned some of the things that you should look for, but I was also thinking about you took cone beam CT.
Sure.
And is this very important for your evaluation to find these 10 to 15% of the patient where it's possible?
I do think that the key factors are, if you have a wide ridge in which I can stabilize the implants apically, 3-4 millimeters of available bone on the palatal side, aiming to the incisal edge. And then, as Maurício was pointing out, have at least 2 to 3 millimeters of gap to fill with biomaterial that can hold the volume. And then the position of the implant is one or the other factor. A buccally oriented implant could be a disaster. I'm not meaning that it will not integrate, because implant, they can stay in the mouth and be integrated only mesiodistally and on the palatal side without any bone on the vestibular spine. But they are stable long-term from the aesthetic point of view? I don't think so. So we are looking for those mainly characteristics: shape, anatomy, implant, and then we do think that the shape of the abutment should be changed. The thinner the abutment, the more tissue that you have. These are the three major messages that I want to give.
Same question to you, Maurício. There are 3 key factors. Tiziano told us 3 key factors for doing a ridge augmentation.
Honestly, I have to say that we have not combined our presentation. It's difficult to have a clash of opinions because we agree with most everything, and I agree with 100%.
You're a specialist.
No. No, you see, that's
No, we have common sense.
we have common sense.
That's a different. That's different.
I mean, it was funny because I mean, our presentations was somehow similar in the message. I mean, it was not on purpose.
Yeah.
And this is true that anatomy is very important. And Tiziano was mentioning about the Batman. Although I am not a prosthodontist, I do agree that the more amount of soft tissue you have on the neck, the better.
But what about the implant diameter? Is that another factor?
Well, for me, I only use narrow diameter implant anterior region of the mouth. I see no biological, biomechanical, whatever reason possible to use a standard diameter implant anterior region of the mouth. I'm not aware of a reason for that. Well, of course, you remove more bone when you do the osteotomy, so your implant surface is closer to the outer surface of the buccal wall. But and this is not for the benefit of the patient, by the way. So it's a matter of implant systems. I understand. I don't know much about implant systems because I just use one. So maybe I'm not the best to talk about implant systems. But you have to have an implant system that allows you to place an implant, removing the least amount of bone, and at the same time have a beautiful crown. I understand that it's not the same for all implant systems, and well,
Yes,
I want to
I
comment
do
on
think-
that.
I do think that over the times we reduce the size of the implant. Another factor may be platon switching, and another factor may be to have some kind of bioactive color that will preserve the soft tissue. That's another adjunct in the armamentarium. But definitely the size, platon switching, and maybe a laced collar or something kind of new technology that allows you to hold the soft tissue and hard tissue.
That's quite in conjunction with the literature, because if you're using wide platform for immediate implant placement, you're getting poor aesthetics and poor results with regard to implant success.
And on top of that, even if it works or not, doesn't work, if you place the implant 3 millimeters below the soft tissue, and it maybe is inside the bony envelope, platon switch, and it helps you in the prosthetic phase. That's it. Very easy, very straightforward.
And do you do see any difference in the aesthetic zone or in the posterior region of the jaw with regard to indication of immediate implantation or socket preservation? Which preservation?
Well,
We are sorry, Professor.
let's just imagine, well, the region in the mouth that you have the largest amount of bone reduction following tooth extraction is the lower molars, right? It's the lower molars. It's not here. However, at the molar sides, you have the largest amount of bone to start with. So even if in the percentage you have the largest amount of bone reduction, what is left allows you to place the implant. So I'm not going to say you that have to do it ridge preservation always. However, if there are situations in which you preserve the volume, it might be interesting, you should do it for it, even in the posterior region. For instance, if you have a gummy smile, a patient with a gummy smile, or if you have a patient with the alveolar process is inside the sinus or is in close contact with the sinus floor and you want to avoid a sinus lifting, another reason for that at the posterior region of the mouth. When I say posterior, it's not premolar, it's molar, right?
So we have to hurry up a little bit. There are so many questions, and one of the mostly asked question, regardless per online or from the auditorium, is the socket shield technique. And in regards to you both, because the questions were, do you use the socket shield technique for immediate implantation? Do you use the socket shield technique for ridge preservation? So short answer, because we have only one.
Short, we have a paper under review with socket shield 5 years data. In the right indication, it works beautifully. But you should not do socket shield because it's fashionable. Socket shield, it takes time, it's time consuming. And you should do socket sheet when there is a clinical indication. And the clinical indication, when you envision that the buccal wall is so thin, so buccally oriented, that the root that you are going to break those little shallow bone that you said is so important. So don't do buccal socket sheet because it's fashionable. You should do socket sheet because there is a clinical indication in our thinking.
Maurício?
Well, in my experience, it's too cumbersome. Too cumbersome. And in my experience, it will be, for me, it's very good. That proves my hypothesis that the periodontal ligament is important. It's very important for me. But clinically, it's really, I would say...
Takes 40 minutes.
Yes.
And
if I can say one clinical thing that it's very important, nobody tells in the papers, is the shield that touches the thread of the implant, you dislodge the shield. So you took 40 minutes to make the shield and 30 seconds to destroy what you have done.
And are you convinced that from the tooth material there's some osteogenetic potential?
Well, there are some papers now using denting. And this is old stuff. I mean, if you go back to the 70s, you remember this papers showing dentin graft for bone augmentation, so it's coming back. Because as we know, there are osteogenic factors in the dentin, or any mineralized tissue except enamel.
Okay, thank you very much for such a nice presentation.
Thank you.
And also answering the questions. We couldn't reach them all. I will only come with a take-home message. It is possible to do immediate implantation, but,
Great.
be careful. You have to be very skilled. I can see very skilled. Okay? You have to select your cases very strictly, and don't do it in aesthetic cases where you need bone augmentation. Okay? Have a nice time. Thank you for being here.
You've just been witnessing are on their way to the forum right here, and we will do a debrief with them to really understand what's just been shared with us, what the key insights are, and of course what the key implications for clinical practice should be. And to make a little advancement for that, we can also take your questions from here that you're still submitting, so keep doing that. Hello from all of you who've been greeting us in the comments. We see people from Japan just now. Good night to you guys all. We see a lot of people in the Americas. Good morning to you, and a lot of people in Europe here as well. So to help me make sense of this battle and to help me make sense of the lecture we've just been witnessing, I'm joined by my expert co-host Sven Mulleman from Zurich in Switzerland. You were here with a little preview. People might have not seen you yet, and then you went into the room. You just got back, fresh out of the room. What is your first debrief? What have you just been witnessing?
Well, two different approaches. And one approach, the immediate implant placement, they were saying it's technique sensitive. You have to select the patient correctly. You have to select not only the patient, but also the site. You have to do a lot of effort regarding diagnostic, regarding the planning. And when we looked at the clinical case, there was also a team approach. It's not only a surgical approach, but also the prosthetic approach, which has to be organized. So, and that this is a highly complex procedure, first. And second, it can be applied in only a low number of patients. So it's really a specific topic. And on the other hand, like the late implant placement with the ridge preservation that Araújo was showing, is like, seems to me a more safer approach, but taking more time.
Exactly.
That's, I think, what we can conclude out of this.
And making this specific about time, you just whispered in my ears. Ridge preservation it might, or augmentation might be common for a lot of you, but maybe for people watching who are not that known in the field. How long will it take before you can take the next step?
Well, we have to wait until the ridge is healed, and it has to be transferred into real bone, which takes at least 4 months. Better I would wait 6 months so that you're really safe once you reopen the site, that you have bone available and that you can achieve primary stability. And ideally, you should not need any augmentation material anymore. That will be the best outcome.
Exactly. And so your resume is, we've been looking at something very special, something very specific. When you were here in the outlook to the session, you said people should be aware we are looking at Formula One drivers.
Yes.
And basically you now also tell us there's only a few Formula One circuits, right? It's not like an everyday drive.
Yeah.
So what is it that an average dentist, or maybe not a Formula One driver, can still take away, because immediate transplant is hot, right? And we talk about patients want it. And so what can we learn from some of the things that Testori has shown us?
That you have to train yourself in order to provide a safe procedure. That's I think the most important.
More training, more practice.
Training. It's like about education, about practicing, about the knowledge. What happens regarding the biology and like dealing with that, and then also if there's anything different that was as compared to my planning, I need to have like an exit. I have to have an option to provide, and maybe it wasn't. They did not talk that much about complications.
Exactly.
And when
during the procedure, you mean?
Yes, during the procedure.
What kind of complications are common in this case?
I mean, an immediate implant placement, you risk to not get primary stability, and then you cannot place the implant. He showed that he placed it freehand, so he did not use a surgical guide. If you do all this diagnostic work with the CBCT scan, I would prefer to also go with a guided implant placement, because then you're more safe to achieve primary stability. So this is, yeah, that's one thing.
Some of the complications that can happen on site, and then there's the whole topic of maintenance.
Yeah.
After the procedure, right?
Yeah.
But I see there's good news. Our chairman are here. So let me address the online audience in the meantime. We are going to spend the next 20-25 minutes to make sure you get the most out of this Battle of the Concept sessions. Unfortunately, our two speakers had to rush off to the airport, but luckily we found our chairs willing to join us here at the desk. Gentlemen, please pick up your microphone. Robert Haas from Viena here in Austria, and Klaus Gotfredsen from Copenhagen in Denmark. Congratulations, gentlemen. That was an intense session. We have a lot of questions online coming in, and you can still send in your questions to us as well. I just did a first debrief with Sven here, walking off stage, reflecting in the distance from here, from the stage to here. What feeling are you left with? What have we just learned about the battle between immediate versus late transplant?
We could see that it was not a yes or a no. It could be both actually, because you could combine it. But I was very happy that Maurício showed us the histology, because it very nicely illustrated that we actually lose some bone. And he also showed that we can do something to preserve the bone. But as all could conclude in the audience, that sometimes we actually, and that's the most of the cases, we need to augment when we have lost a lot of the bone. And that was illustrated very, very nicely. And I think, as I also said as the end comment, that you need to be very skillful if you have to do it, to do the immediate placement in a predictable way.
Yes, Sven has been referring it here in the forum as this is Formula One driving, right? This is not your average commute to work.
Yeah, it is for sure. And what you have to have in considering that if you make the ridge preservation, you prevent the ridge for collapsing. But it doesn't actually tell you about the amount of new bone you're getting. And Araújo has published a second paper where he said you can keep the bone, but it some kind of prevent the new formed bone to grow as if you don't do anything. So, like always in nature, there is not only advantages, there are also some disadvantages. Yeah. So you keep the volume, but you have to consider that you may prevent the new bone from growing too.
Exactly. Now, building on that, we saw Maurício spend a lot of time on the biological argument, right? To what extent is that the only parameter to consider here?
No, it's not the only.
Exactly. So what are the other things we should?
The other thing, especially when considering the immediate implantation, it's a very accurate procedure actually. It doesn't seem so, but it's a very accurate procedure. You have to consider the position of the implant in the buccal distal aspect. You have to consider the position in the depth of the implant. You have to consider if there is a gap, not too small, not too large. If you remember, the immediate implant is not new. We have had it with Schulte. Schulte for 40 years ago already has promoted the immediate implant, the tubing immediate implant. And I remember as I was a little starting with my career as a pelotologist, he said, oh, everybody warned to not touching the buccal plate, buccal bony plate with the immediate implant. And now what are we doing now? We say, no, don't touch it, don't touch it, don't touch it. Save it, keep away.
Exactly.
So there are some adaptations to the actual protocol.
I agree that the biology is not the only point which is important, but I think one of the questions that was not answered during the session was that how can we know where the bone collapse will end or where the level of the bundle bone stopped actually, because that can be very difficult to predict. And then we may place some implants when we do it immediately where we have a bone dehiscence. And how does this bone dehiscence influence the long-time results? There have been some newer publications indicating that the risk of having peri-implantitis may be increased a lot actually if you have relatively rough, moderate rough surfaces exposed actually outside the bony envelope. So I think that is an important issue. So you have to be very sure when you place them. And I think there is a tendency, don't you think so, Robert, that when the implant is done immediately, and I could see you do that too, then you place maybe the implant a little bit deeper to be sure that you will not have exposed part of the implant.
Yeah, that's quite important. You have to be very aware that you have it deep enoughly placed, because you have to be sure to be in advance of impossible resorption. And another aspect Tiziano stressed on when he made the final statement to speak of is the abutment.
Yeah.
The abutment in looking at the immediate implant is of utmost importance. We do believe in that. And we have had, when you're looking at our patients, we have had some tremendous failures, aesthetic failures, because we didn't pay much enough attention to the abutment.
What are the most important parameters regarding the abutment? Is it the material? Is it like the design?
No.
What is it?
It's not the material. It's the material. It's keeping away from the soft tissue as well. So when you insert the abutment, you have to be very, very, very sure that you do not do any pressure onto your soft tissue. Putting a pressure on the soft tissue will immediately retract the soft tissue. And we have made a lot of pictures because we're doing some lectures and we need pictures for presentations. And when we looked at a bad outcome, aesthetic outcome on our patients and looked when did it happen, it didn't start slowly, and in the end we saw a recession of the soft tissue.
What happened?
We saw it immediately when we put onto the abutment on the immediately placed implant. It was iatrogenic.
Because you interfered with the soft tissue in the procedure.
Yes, we didn't pay attention to that.
But I also think Tiziano mentioned that he would like to have a narrow abutment, and one of them he showed was almost concave instead of convex, and I think that should be seen a little bit in relation to that you normally place the implants a little bit deep in the bone, and then you need actually, against earlier what we have learned, to have it very narrow in the apical part and be careful not to make, as you said, the pressure. I think really you need a skillful dentist who have a lot of experience also to do this in the right fashion, to have such a nice results as Tiziano showed today.
And what we saw also this morning, and also now he showed it in the Clínica, so a team approach between the surgeon and the prosthetic.
Yeah.
Sure.
And that then immediately limits this to the larger practices, right? Because this is not available for everyone.
My personal opinion, yes. But if anybody feels educated enough to do everything, I don't.
No, exactly.
I'm a surgeon and I love surgery, and I love when after surgery I can say to the patient, oh, move to the prosthodontics, I don't have to do that job. And you're a specialist in our fields, and especially the immediate implant, immediate restoration is very, very sensitive with the proper work done.
Exactly. Well, and you're being applauded by our online audience. Caroline Lupi is giving a hands up and applause in the comments, which means we're still live. If you have any questions or reflections on this session, make sure you type them in the comments. I'm keeping an eye on the screen, and I can relate your question to our experts here immediately. Now, we talk a lot about the procedure of the immediate implant, which is highly technical and not that common. However, there's also quite some challenges post-operation, right, in the maintenance and what can happen then. Can you elaborate a little bit, because this might be relevant for a broader audience who might, as a regular dentist, come across an immediate implant that is failing or that needs specific care. What are things to consider there?
You have to consider that you have about double as much implant failures, losses, than the late approach or the early approach, which means after healing of the soft tissue. But if you look at the topic, which means actually you lose at the late or early group about 3 to 4% within 10 years.
So it's not
So
up to 30 or 40%.
No. So we have to keep the
marginal.
right relation. But if you look at the time point, when are we losing immediate implants? We are losing that in the first 6 months.
Okay.
And the latest one we are losing at 10 months. So if you want to be very on the safe side, on the side that the complaints from the patient are not that much, you have to extend the provisional phase. You have to extend the time before you're doing the final crown, the final prosthetic treatment.
Exactly.
And if you lose the immediate implant, then actually nothing happens, because you're now switching in the early failure implantation or the late failure implantation, like you would have done
Anyway.
Exactly. So considering the immediate implant, we have to say the other way around. We have to say 94% of the patients are successful and are in favor with the immediate implantation. They only have one operation at one time. They have the immediate restoration at one time. They have anything done. They experience much less pain, and only once.
Yeah.
And if for the 3 additional patients, or 3 to 4 additional patients, that they are not in favor, they are failing, okay, they switch and they have the routine procedure.
So you're saying from a protocol perspective, let's go for immediate as much as we can, because if that fails, we're still back
but
on
this
the other
is
scenario.
seen only from the failure rate to see.
Exactly.
So we have to consider the prosthetic,
Klaus,
the
you're in doubt, I see.
Yeah, and we shouldn't forget the patient, because we have so different patients. You know, someone come and would like to have a very quick solutions, and others will have the safe one to be sure to have the best prognosis the whole life. And then I don't think we should go for the immediate models. I think that also when you come to this with a temporary crown, I think one thing which is quite important that you have a primary stabilization, because we know if we make it temporary and it will be in function where you have a jiggling movement, then one of the risks have been shown many years ago that if you have these jigglings, that could be one of the reasons that you would not have such a good results. So therefore I think you have to be very careful how you also do the provisional crown and don't have any problems with that. And then of course I think also that it's important that you have good oral hygiene and good instruction of the patient. But I think the patients are very different, and you may have patients who come in your clinic and who want to take the risk. And then if you inform them that you have the risk and what you can do if something is going wrong, but we need to inform the patients before we do the procedure that it is a higher risk.
Yeah, and I must admit the way you explained it just now, Robert, is quite clear for a layman, right? I mean, you have two options. We can do the risky one, maybe write them once, or you're back twice, or you go for twice anyway, right? I think that's easily to
That's
explain.
true, and obviously we've been selected as moderators for this session quite because you're in favor obviously for the more late
Exactly.
I'm in favor more for the immediate implantation.
Well, and our audience is picking up on that because we're getting a question. Or you want to make
just one second. If you look at the failure rate post the first 10 months, the late and the early implant is quite the same failure rate to the immediate implant. Then those different kind of placement procedures do not differ anyway.
Okay.
Not at least this 10% of a percent.
In the current available data and literature and science. Let's go to a question which is back more onto the practical procedures and planning of this this operation. It's from Klaus von Baumgarten. Thank you very much, Klaus. It's Klaus and Klaus. And it's a practical question about how do you know the right depth of the implant, and what orientation points do you have to determine that? Robert, I see you nodding heavily. You recognize the question.
Yeah, this is of utmost importance. You have to be aware that you completely change the way of looking at an implantation when you do immediate implantation.
Exactly.
You do not know where the underlying bone is unless you're doing a completely guided implantation, which actually, to my opinion, is quite not that easy like it is in a late implant placement. But you have to have another orientation point. And for us, it's the soft tissue. It's the most apical part of the soft tissue, of the sulcus. And we try to be underneath 3 to 4 millimeter from that point.
Okay.
And when
the 3 to 4 is by practice?
No. We have done, as I've been at the Viena University Clinic, this was almost 15 years ago. We've made a retrospective study with looking where worst and where best aesthetic results with regard to implant position.
Okay.
And we did a lot of measurements from the casts we have had post-implantation and looked at some correlation. And the single only parameter that proved out to be of utmost interest was the position of the implant, of the depth of the implant and the posterior position of the implants. 3 millimeter posterior at least, and 3 millimeter down underneath the soft tissue, the E-point we called it.
Yeah. Well, sounds like a very hands-on and practical answer, Klaus. I hope you are good with that. And an invitation to all our other viewers we still have. If you have questions like these, here are our experts to guide you. Now, zooming out step by step, we looked a little bit at maintenance. We got back to the patient's needs and the patient management. Because when we started this session, we talked a lot about why is this topic so hot, if from a scientific or maybe a clinical practice professional perspective, going late and slow is much safer, much predictable. So what is the key takeaway that we should tell our patients from this session? What can we do in the clinical practice tomorrow to put this in the right perspective?
I don't know whether I'm the correct one to answer because I normally don't do immediate implantations because I would choose the most safe and predictable way. But there may be...
so Klaus, the question really is, so what do you say to a patient that comes in your clinic and says, well, I've been watching this EAO live stream and I've learned that now in 5 hours they do live surgery, they can immediately extract, implant and actually prosthesis on it. So Klaus, why are you so slow?
I will tell them about the risks and then I'm sure that they will change.
but Robert just says the risks are marginal.
Yeah, but you can see the survival is very good. But you know, we are also talking about young people who have fracture of their teeth. Okay, where it has to stay there for many years, and where I think it's very important that we know where do we have the level of the bone and in conjunction to where we place the implants. Of course, I can see cases where it could be an option. To do it, you know. I've had once an opera singer actually where I did it because she was...
time pressure.
Yeah, and she had a tooth and it was fractured and she was doing it every night. So she came at the clinic and we extracted, we took impression and then we extracted the tooth, placed an implant and a temporary, which was like the tooth she had before. So she had the same sound as she had before, so she could go out and singing. So that was really, I would call it an acute situation. It was a quite simple case, but so there may be cases, but for me it has been very seldom at least.
Exactly.
Yeah, to give some guidelines. Immediate implantation is not the beginning indication. So if you start with implantology, don't do immediate implantation. Get you acquainted with the procedures, get your experience, get your failures in cases where you for prosthesis patients, for edentulous patients, but not for immediate implantation. Because immediate implantations, most in the cases are single tooth cases or cases in the aesthetic zone. So if you proceed with that procedure, slowly. Take your time. The second one is, if you're doing immediate implantation, you almost try to make an immediate restoration. Because you're doing immediate implantation in order to save aesthetics. And if you look at the recently published meta-analysis from Tonetti and Lang, and they argued, their statement was, so in the aesthetic zone, don't do immediate implants. But if you look on the underlying papers they extracted their knowledge from, they also, they mostly included flap elevation, keeping no distance, wound closure, not immediate restoration, and things like that. So if you look at meta-analysis, you have to be very aware of the underlying procedures. So once again, don't start with immediate implantation. If you do immediate implantation, do it in immediate restoration. And yes, you have to tell the patient that it's about 3 of 100 patients that won't be in favor with the procedure.
But never in our practice. But no, that's a bad joke. Sorry, I won't make that comment. Sven, let's end with you, my expert co-host, who is not yet really in favor and actually served late. What is the key thing you take away from this 2.5 hours here at the EAO Congress? What is your main learning?
Well, it was already said. Immediate implantation is a complex procedure. You need to have the skills. You need to select the patients correctly. You need to select the sites appropriately. So that's what I take out of this session. And the late approach is maybe takes maybe more time, but it's more safer, and I don't have the risks. But it depends also on your skills.
Exactly.
He's highly skilled, and he does this every day.
Yeah.
And in his hands, it's working, and that's something you should know.
So I guess the key lesson for an EAO community is we need to work together. If you feel you're not the right guy to do this, find a peer or a colleague in your country or international that you can refer your patients to. Robert, you wanted to add something?
Yes, one practical tip as well. If you want to begin with immediate implantation, start in the upper premolar region. That's the most easiest region. It's not the aesthetic region, and if there is I won't say a defect of the bone, but if it's not on the uppermost part of where it could have been, that's an easier region to start with.
All right. Thank you very much, Robert. Thank you. Klaus, thank you. Sven, thank you. And thank you for being such an active participant in our EAO online congress. I hope you've been enjoying it. Thank you for all your greetings from all over the world. And if you know anybody who is interested in implant dentistry, hit that share button right now. Share this video with all your friends and family, either on Facebook or off Facebook, so make sure that the key learnings and insights are being shared. If you like being part of the EAO Congress here in Vienna online, make sure you block your Saturday morning if you're in Europe, you block your Saturday afternoon if you're anywhere in Asia, and I guess for you guys in the Americas, you need to stay up all night, because tomorrow morning we'll be with you from 8:30 Vienna time all the way to noon. We have a full morning of live broadcasting where we first will follow the Battle of the Concepts, which is all about titanium versus zirconium. What is real, what is the risk, what are the complications, and where are we with this new material? And right after that, we'll have a reflection on the Congress with Michael Peyer, who is one of the co-chairs of the scientific committee, together with the two speakers of the closing session tomorrow here in Vienna, which is all about our implants for life. So a lot of interesting nuggets there for you. So I hope to see you back tomorrow morning here live at the EAO Facebook page.